Good morning and thank you. Now let me just get my glasses sorted out. That's better. Okay. So, yes, as Kylie explained, we're an independent not-for-profit organisation, largely funded by the Commonwealth Government Department of Health. And our aim is to enable people to make better decisions about medicines and other medical choices, and that includes for health professionals and consumers, and thereby achieve better health and economic outcomes. And we conduct national therapeutic programs. That's one of the important ways in which we work. And our usual approach in doing that is while keeping an eye on the consumer perspective, we identify problems in the quality use of medicines and medical tests, draw out the clinical issues, try and understand the barriers and enablers to better practice, develop key evidence-based messages which we promote via a mix of interventions to try and sort of overcome some of the barriers and use enablers. And we do that across disciplines and sectors and then evaluate our success or not. So we've been conducting work in improving antibiotic use in the community for some time. We've been in existence since 1998 and there's been various programs since then. If we look at antimicrobial stewardship and some of the components which are important, there's similar components which are important in institutional settings, but there are different sorts of challenges. Governance and leadership for AMS is more distant and distributed. Education is less prescriptive and it's probably more critical, obviously for consumers. There are many rules and tools. The PBS provides rules, there's many guidelines available, there's different tools, but they're probably somewhat discretionary in interpretation at times. Audit and feedback are undertaken, but it's largely voluntary, although incentivised. Monitoring antibiotic use, obviously ORA are doing a tremendous job around that, but it's more difficult to interpret the data. Similarly for resistance work, and evaluating the performance of antimicrobial stewardship nationally in community is quite a challenge. I think most of you would have seen this graph of antibiotic use over time in Australia. It represents national antibiotic use. We saw a reduction in antibiotic use at the turn of the century, and then we saw an upsurge again in the mid-2000s. MPS had been conducting programs earlier in the century and then stepped away from it for a period of time, but we've now, since 2009, stepped back into it again. So you can see that if you don't keep at it, problems can occur. So since 2012, we've been conducting a 5-year program to reduce inappropriate use and prescribing, as well as improving consumer knowledge. We've worked with health professionals with a considerable focus on respiratory tract infections, UTIs, urinary tract infections, and skin and soft tissue infections, as well as conducting consumer campaigns, especially during the cold and flu season, and sometimes with a particular focus in workplaces, schools and childcare centres, as well as doing things during Antibiotic Awareness Week. So looking at consumers more significantly, so our overall strategy is to engage and educate people about the problem of antimicrobial resistance and then empower them to be part of the solution. So our focus groups have demonstrated that people perceive that the benefits of using antibiotics can outweigh when used for cold and flu than any personal cost. So they believe that they can recover faster from cold or flu with antibiotics, that they're relatively safe, that they can go back to work, that kids can go to school, etc. So just to demonstrate in terms of how we might use those sorts of findings, a consumer truth, you might say, is people underestimate the impact of coughs, colds and flu, but they overestimate the benefits of using antibiotics. So our positioning is that antibiotics won't speed up the recovery from cold and flu. Similarly, people might say that antibiotic resistance is someone else's problem and not theirs. And so our positioning is that you could be responsible for antibiotic resistance. So in addition to developing key messages, we've got to consider what sort of social marketing strategies we might use. And so we've used celebrities to endorse our work. We've used notions of collectivism so that people can start thinking about what might be of some national or societal importance rather than what's important to the individual. Using nudge techniques, for example, taking a pledge. Encouraging people to imagine a world without antibiotics by distributing different types of videos. Gamification for kids. And starting to challenge ideas of what is a normal sort of practice. In addition to that, to really encourage a different level of creativity and reach different audiences, we've partnered previously with Tropfest to develop short films to elicit the problems of antimicrobial resistance. So I'd really encourage you to look at the MPS YouTube site. These are fantastic and very short films that really well describe some of the problems, and some of them are very entertaining. We're doing something similar again this year. We're partnering with AMEX Open Air Cinemas for a short film competition on the same theme. So turning to health professionals, some of the issues that we've elicited through our research, barriers such as the uncertainty of diagnosis, there may be medical legal concerns about missing serious infections, that there are always time pressures in terms of people sort of moving through the clinic. There are also beliefs that patients expect and sometimes want antibiotics, but sometimes that can mismatch with actual expectations of consumers. And that it can take longer and even more effort to have a conversation with patients about why antibiotics are not needed than simply writing a prescription. And that writing a prescription can signify in a neat way the close of the consultation. So when we're developing our interventions for health professionals, we think about them in different ways, and we're trying to address different perspectives on the problem. Of course, we develop information or knowledge resources, but we know that on their own they have uncertain impact on behaviour. For more junior doctors, for students and other sort of junior health professionals, we develop principles of how to make good decisions, and so we embed that in different online learning tools. We also encourage activities for GPs and others to reflect on practice between decision making, and we're increasingly developing tools that can be used when decisions are actually made. So, as I said, we develop different information resources, and although they on their own can't be expected to change practice, they are important foundation for different work and can certainly sensitise the issue. We use feedback reports to GPs from time to time. So this is an example from 2014 where we use PBS data and develop a report comparing an individual's practice with either clinical indicators or their peers, and distribute that to all GPs across Australia. We're now using a program called MedicineInsight, which includes over 650 general practices across Australia now. That's about 3,500 GPs, so I think about 15% of GPs and about 10% of the Australian population. And what it includes is we're extracting de-identified data from the clinical systems from general practice, which obviously gives us greater insights into the reasons for use of medicines and medical tests and different other insights into practice, and can then provide that feedback to general practices for their reflection. A key strategy for us is using general practice educational visiting, and we do that largely in two ways: conducting one-on-one, face-to-face educational visits or academic detailing with GPs. We have a field force that goes out and has the ability to reach general practices across Australia, or conducting small group discussions which are based around case studies or practice data, such as from MedicineInsight. And we develop tools that can be used at the point of consultation. So this is an action plan for managing symptoms of respiratory tract infections, which can be used by GPs or practice nurses. And so it's to be able to manage that expectation sometimes for a prescription, as well as providing useful advice to consumers. There is a number of other interventions that we deploy, including online learnings, activities and data reports for residential aged care. Community pharmacies are an important site because, in fact, consumers visit community pharmacies probably 5 or 6 times more often than they do GPs, and so it's a great opportunity to provide education and awareness. So turning to the evaluation, we've done quite a lot over several years, so I'm only presenting on a few aspects here today. We conduct national consumer surveys, and you can see around this question of whether or not antibiotics kill bacteria and not viruses. Through that survey, there's been an improvement in knowledge around that. So whether or not that actually translates to different behaviour, it's a bit hard to say, but it's a useful understanding for people to have in terms of understanding the rationale for not using antibiotics for colds or flu. This compares our survey from 2014 and 2017, and there's been a slight improvement in terms of the numbers or percentage of consumers being more aware of antibiotic resistance. But do they understand really what is antibiotic resistance? That's another question and more difficult to ascertain. From our last survey, we've asked questions about their belief in terms of how long symptoms may last for upper respiratory tract infections experienced by a child. And there's an expectation that they should last less than 1 week. And yet we know that for upper respiratory tract infections, particularly cough and cold, they can last considerably longer than that. And that doesn't signify necessarily the need for antibiotics. In terms of GPs' response to our programs, surveys have compared GPs who participated in the 2012 program versus those who did not. And we found that those that participated reported more frequent discussions around hand hygiene and, for example, the appropriate use of antibiotics. But I guess getting down to what's more significant is whether or not we've made an impact on antibiotic use. To do that, we've undertaken a Bayesian structural time series analysis of 13 antibiotics available on the PBS, which are commonly prescribed for upper respiratory tract infections. We've looked at all those antibiotics prescribed for concessional patients between 2004 and 2015. And we've also been able to look at the prescribing rate for non-GPs and use that as a covariate in the model. We've constructed a counterfactual forecast of what would have happened in the absence of the intervention. So I'm not sure how clearly that's coming across on the slides there, but the top panel represents the GP time series. And so the black line represents the actual prescribing, and the dashed line represents the counterfactual, what may have happened in the absence of the program. The second panel represents the trend for non-GPs. And so you can see there's something happening which is different than it's happening for GPs across these antibiotics at least, but prior to the interventions there was a lot of similarity in the trends. The bottom panel represents the estimated average monthly decrease in dispensing since 2009. And this represents a 14% reduction for these antibiotics. So looking at it from a slightly different angle, looking at the monthly prescribing rates for these antibiotics, looking at GPs versus non-GPs. Again, the black line is for GPs and the red line for non-GPs. Something different occurring there. So to conclude, the national community programs have, we believe, resulted in less GP antibiotic prescribing. So I think there has been some impacts in particular areas from the AMS activities. Programs do need to be designed both for health professionals and consumers, and multiple strategies are needed for the different audiences and need to be sustained over the longer term. But continued education is essential, but alone it's not going to be enough to achieve rapid additional reductions if that is the goal.